Thanks for joining us again at the Canadian Breakpoint, a Canadian infectious diseases podcast by Canadian infectious diseases physicians. I'm Summer Stewart, here with Dr. Rupeena Purewal, pediatric infectious diseases physician in Saskatoon. For today's episode, we welcome back Dr. George Zhanel to share CLEAR Registry results for IV AmoxClav. Dr. Purewal.
All right. Welcome, everyone, to another episode of our podcast, The Canadian Breakpoint. Today, we have Dr. Zhanel back with us to discuss the CLEAR Registry. And as many of you know, he's a microbiologist and pharmacologist who received his PhD in the Department of Medical Microbiology and Infectious Diseases, the Faculty of Medicine, University of Manitoba, and a Doctor of Clinical Pharmacology at the University of Minnesota, the magna cum laude. He's presently professor and associate head, Department of Medical Microbiology and Infectious Disease, Max Rady College of Medicine, and research director of the Canadian Antimicrobial Resistance Alliance. Dr. Zhanel is the founding and chief editor of the CARA website. Dr. Zhanel has published over 1,200 papers, scientific abstracts and posters, and book chapters in the area of treatment and prevention of infectious diseases. He's presented over 1,300 lectures as an invited speaker to international, national, and local meetings, speaking on the topics of antimicrobial resistance infections, as well as the treatment and prevention of infectious diseases in pretty much all over the world, in Canada, US, Central and South America, Western and Eastern Europe, including Russia, Australia, Southern and Northern Africa, the Middle East, and Asia. He's been extensively involved in the treatment guidelines for a variety of infections in Canada, the US, and internationally. Dr. Zhanel has received or been nominated for more than 110 teaching awards, including the Canadian Association for Medical Education Merit Teaching Award in 2020. Dr. Zhanel is a member of the Who's Who in Medical Sciences Education. In 2022, he was elected as a Fellow of the Canadian Academy of Health Sciences in recognition of sustained excellence in research and teaching within the health sciences. Fellowship in the Academy is considered one of the highest honors for individuals in the Canadian health sciences community. Also, in 2022, Dr. Zhanel received the Dr. Fred Aoki Career Achievement Award in recognition of a career of dedication and excellence in multiple domains of medical microbiology and infectious diseases, including research, education, clinical practice, service, and administration. Each year since 2022, Web of Science identifies Dr. Zhanel as one of the world's most influential researchers, selected among an elite group recognized for exceptional research influence, demonstrated by the production of multiple highly cited papers that rank in the top 1% by citations for field and year. So we have an amazing speaker today, and we are talking about probably the most awaited topics for me, because I wanted to bring up IV AmoxClav into the CLEAR Registry, and super excited to hear some of the results and analysis that you guys have done with the CLEAR Registry. Thank you, Dr. Zhanel, for being here today and always taking the time to support the podcast.
Dr. Rupeena, for me, it's an honor to be with you. I do apologize. My mother sends out these prolonged biographies, and your listeners have to suffer through them. So I apologize for that. Hopefully the rest of the podcast will be much shorter and clearer.
No, we love hearing about all of your accomplishments, and honestly, they're commendable. So we are just honored to have you here. And so I think for some of our listeners, they have heard of other CLEAR Registry episodes and tuned in, but for some of them who have not or haven't had the chance to yet, can you remind our listeners what the CLEAR Registry is, what it does, what does it encompass, and what's the ultimate purpose of the registry?
So CLEAR stands for, and it's just spelled CLEAR, stands for the Canadian Leadership on Antimicrobial Real Life Usage Registry. And essentially, it's a voluntary and free data sharing service. I have some 450 CLEAR participants across Canada. About half of those are infectious disease, microbiology specialists, and about 50% of those are clinical pharmacists interested in infectious diseases and stewardship. And what happens is if Canadian clinicians are using new IV antibiotics like IV AmoxClav, they teach
Mhm.
each other about when, how, and why they use these new IV antibiotics in the Canadian setting. And all we do is just facilitate this. So, right now on the CLEAR site, we have links to antibiotics such as IV amoxicillin clavulanate. And what happens is all of our participants have these links. I send them out every 3, 4 months. And the participants who've used IV AmoxClav, for example, or will use it, they can
Mhm.
hit one of these links and 17 questions pop up. Point and click, point and click, point and click. You're done in 3 minutes. And then I share the data, I crunch it, and I share it with all the CLEAR participants every 3 to 4 months. So the good news is we're going to have another data crunch of IV AmoxClav first week of September. So if
Okay.
you're a CLEAR participant, you'll get that. If you're not a CLEAR participant, it's a great opportunity to join.
Awesome. It sounds like fantastic work, and we've seen it with the other antimicrobials and how much information that you've been able to provide Canadian prescribers and also international prescribers. So super excited to see more of this data come through. And so for specifically for IV Amoxiclav, when did we start collecting this data and what specific data have you collected thus far?
We started collecting data in June of 2024 for IV Amoxiclav, and we've collected a whole variety of data of why clinicians in Canada use this drug, when and for what types of infections and pathogens they use the drug, and how they use it in terms of dosing and infusion. And we also have very good data on safety.
Perfect. Yeah, and we're gonna go right into this and talk about what specific age group then are you seeing most often that's prescribers are prescribing IV amoxiclav and which indications?
So, in terms of age,
Hmm.
5% of all the usage is in pediatrics, and I'd love to get more pediatric use because this agent is indicated for all ages. And then
Right.
we have a lot of use in patients 65 years of age and older, and then patients 18 to 64. So 90% of the use is in a 95% of the use is in adults and
Okay.
5% use in children. In terms of infections, it's very interesting.
Hmm.
Clinicians use IV amoxiclav for both on-label, so infections that are covered by Health Canada, but also off-label, which is very consistent with the way clinicians work. They basically look, I know about the drug, it's safe, effective, I'm going to use it when I think I need to use it. Our biggest use, 23%, is intra-abdominal infections, followed by acute bacterial skin and skin structure infections. Thereafter, cystitis and pyelonephritis. Community acquired pneumonia is also a big indication, as well as ear, nose, and throat infections, bone and joint infections, and also a variety of female genital type infections. So it's used all over for
Yeah.
a whole variety of infections.
Okay. And are you looking at the kind of the status of the patients? So are they admitted to the ward? Are they, in the ICU? Are they very ill? Are you able to see some of that prescriber information as well?
Yes, we are. So, in terms of bacteremia,
Hmm.
only about 19% of the patients have bacteremia when they're being treated with IV amoxiclav, and only about 11% are in the unit. So the majority of these patients are on the medical ward, surgical ward, or in the emergency room. Not many are critically ill. Interestingly,
Hmm.
about 50% of the time it's used as directed therapy, where clinicians actually identify and culture a pathogen, whether it's a staph or a strep or E. coli or Proteus or other organisms. And the
Okay.
other 50% of the time, it's used empiric. Clinicians don't really know what the pathogen is yet, but they have a pretty good idea based on the infection that they are treating. So 50% directed, 50% empiric use.
Okay. Yeah. And then for the directed use, what's kind of the number one pathogen that was identified that it was used towards? Was it mainly E. coli?
So 50% of the time, no pathogen was identified
Okay.
and the drug was used. in 26% of the time, it was actually a mixed infection, a combination of E. coli or another gram-negative and another gram-positive or even an anaerobe. And then the other 25% organisms grew out: E. coli, streptococci, Klebsiella, enterococcus, staphylococci, or potentially even an anaerobe. So the majority of the time, patients are on IV AmoxClav. They don't have an identified pathogen. The treatment is simply empiric, but in a significant chunk, it's a mixed infection, mixture
Hmm.
of gram positives and gram negatives, or potentially even an anaerobe.
Right. And you mentioned like intra-abdominal infections being kind of one of the common uses. And obviously, as clinicians, we know that those are usually polymicrobial infections. And so that's kind of the comfort with using the IV Amoxicillin because of its broad range of coverage. So in terms of the providers, is there a specific dose? Because I know that in pediatrics, there is kind of a standard IV dose, and then there's also a higher IV dose that you can use. And so I don't know if that's been looked at, or is it mainly kind of the adult information? Because the majority of the participants have registered kind of adult use. Is there a specific dose that you've seen that providers have been using?
Yeah, so we've captured dosing and also renal function. All
Okay.
of these patients have had their renal function assessed, and dosing has been based on a combination of infection, severity of illness, but also renal function. By far, the most common dose
Hmm.
is 1,000 slash 200 milligrams Q8H. The 1,000 is the amoxicillin, 200 is the clavulanate every 8 hours. And then two other doses that seem to be quite common are
Hmm.
2,000 slash 200 Q8, as well as 500 slash 100 Q12. And again, that's based on renal function. But by far the most common dose is 1,000 milligrams slash 200 every 8 hours.
Okay. All right. And then in terms of once prescribers are using this in terms of therapy, is it often used as monotherapy or combination therapy?
By far, 84% of the time, it's used alone.
Hmm.
When it is used in combination, it's used in combination with a whole variety of different agents because of the different infections that are being used. But frequently, it's used along with vancomycin or a fluoroquinolone, such as ciprofloxacin or levofloxacin, or with a macrolide, azithromycin, or doxycycline. But the majority of the time, it is used alone.
All right. And then in my experience, I've, used it and not had any specific, adverse events that were severe. And so is that kind of what you're seeing in the registry as well, or are there any specific side effects that should be brought to our attention?
As expected, we've had hundreds and hundreds of patient cases reported now, and overwhelmingly, the drug is unbelievably safe. In 98%, we've just had no side effects reported whatsoever. Sometimes the clinician doesn't know if any side effects have occurred, but overwhelmingly, 98% of the time, no side effects. We had two side effects reported. One was rash. The other
Okay.
one was a transient leukopenia, but I'll say that neither one of these two resulted in drug discontinuation. So, no surprise, it's a beta-lactam, it's a penicillin. This is an astonishingly safe drug.
Sounds fantastic. So, in terms of obviously all the clinicians and pharmacists out there and nurses are thinking, so what are the outcomes in our patients? I know that CLEAR looks at microbiological cure rates and then also clinical outcomes. And so, what have you seen with IV amoxiclav?
So I'm going to talk about both the microbiological success and the clinical success, but it's very interesting, and I think your listeners will be interested. Why? Why
Hmm.
are clinicians choosing IV Amoxiclav? This is an antimicrobial stewardship play, I think, in most hospitals. 40% of the time, they're using it instead of piperacillin tazobactam. They're choosing the narrower spectrum. 15% of the time, they're using it instead of ceftriaxone. They're using it instead of meropenem and ertapenem. They're using it instead of other antimicrobials such as fluoroquinolone. So, large part of its use is
Hmm.
an antimicrobial stewardship strategy, use it instead of things like peptazo, ceftriaxone, a carbapenem, a fluoroquinolone, which is wonderful in terms of trying to preserve drugs such as piperacillin tazobactam for the future. Now, in terms of microbiological outcomes and clinical
Mhm.
outcomes, the data is overwhelmingly supportive. Microbiological success, which is what we call eradication of the pathogen or presumed eradication. As you know, Dr. Rupeena, I'm a microbiologist. I like to kill bugs, and AmoxClav, no surprise, it's killing them. 87% microbiological success, meaning the
Yeah.
pathogen has been eradicated or it can't be found after treatment, which is really great news. And in
Right.
terms of clinical outcomes, you're very interested in making patients clinically better. 87% clinical success based on either improvement or clinical cure. So, wonderful news regarding safety, but also very, very good news in terms of efficacy.
Yeah, and like you mentioned, it gives us an alternative option, right? So sometimes when you don't want to use Piptazo or you don't feel like there's a need to use it, you have another option. And I think when IV, the formulation came out, because I think oral AmoxClav everyone's been using for a long time, and then when the IV formulation was released, I think a lot of us benefited from that, from both like an antimicrobial resistance standpoint, stewardship standpoint, like you mentioned, but just awesome clinical cure rates, and then also patient compliance, and just patient satisfaction as well, because it's that one drug kind of method. And oftentimes, for intra-abdominal infections, we sometimes have to use combination therapy. We're using like ceftriaxone because we need better anaerobic coverage with that, and or even with ciprofloxacin sometimes. And so I think IV Amoxclav has really helped with patient satisfaction as well, because you can present to them that, it's a single 3 times a day medication that we can give through your IV. And so they can go, especially for pediatric patients who want to go on passes in between antibiotics, it really helps.
So, you talked about oral amoxicillin clavulanate, which has been available in Canada since the
Mhm.
80s. And just so your listeners know how old I am, I published a paper on oral amoxicillin clavulanate back in 1986, Dr. Rupina. So
Wow.
your listeners are listening to a dinosaur talking about this drug. But we have been trying to get the intravenous version to Canada for many, many years because it's
Yeah.
been available in many countries such as France for many, many years. And we're delighted to have it here because 15% of the time, clinicians want to use a AmoxClav, but they want to use the IV. And that's the
Yes.
reason why they're using it is, look, I really want to use this drug, but I need the IV. Patients can't take oral. So it's wonderful we have this drug in Canada.
Yeah, it's fantastic. And we have information and analysis of how it works, and side effect profiling because of a CLEAR registry. So I think it helps prescribers. So moving on to any specific resources, obviously they have CLEAR registry data and information. Are there any publications and posters that our prescribers can review or present locally to their centers if anyone has any questions?
So we had a poster in Calgary in April at the AMI meeting. That's the Canadian Infectious Disease Microbiology meeting.
Mhm.
And reviewer and your listeners can look at that poster. But I also want to throw out a pitch. If you're not a CLEAR participant, just send me an email. Google George Zhanel. You'll find my email address. Or if you've got a pen and you can write it down, it's ggzhanel, Zhanel at pcsinternet, all one word, .ca. You can just send me an email and you become a CLEAR participant for free, and it's voluntary. We're going to be doing a data cut this September, probably in the first week of
Okay.
September. So in 2 3 weeks, I'll send out the most current data of IV AmoxClav. And if you're a CLEAR participant, hit that link. Let us know how things worked for you when you use the drug. And if you just joined CLEAR, I will send you all the data come the middle, late September. So if you're not a member, join and you'll get the latest data on IV AmoxClav.
Awesome. Sounds fantastic. And then in terms of how long we're collecting this information for IV AmoxClav in the CLEAR registry, is there, like, will you be, like, should prescribers continue submitting the data up to a certain date? Are you planning on doing some long-term work with this?
So thanks for this. I see each of these new IV antimicrobials being on the CLEAR registry for about 3 years. So as of today, we have intravenous dalbavancin, we
Hmm.
have intravenous meropenem vaborbactam, and also intravenous ceftobiprole, but only if you're treating endocarditis. Of course, along with IV AmoxClav. And I see each of these drugs being on the CLEAR registry for about 3 years, where we send enough data to all the Canadian clinicians, show enough AMI posters, publish enough papers so that Canadian clinicians feel very comfortable with this drug. Where are we with IV AmoxClav in this cycle? We're about a year and a half in. I'd like to get a lot more data
Awesome.
before Christmas of this year, put together another AMI poster, which will be presented in St. John's in 2026. Then we'll also put together a paper and the most common contributors to
Hmm.
the IV AmoxClav site will be invited to be authors, like they are on the AMI poster. So I'm hopeful that we would continue gathering data for IV AmoxClav for at least another year and a half. But my
Okay.
big goal now is between now and Christmas, trying to really ramp up lots of data and especially pediatric data if clinicians are using the drug in children.
Awesome. Sounds fantastic. So we will all submit our cases and get some more information on IV Amoxiclav. I think it's been in my practice. I use it all the time, and I'm excited to see what other prescribers are doing across the nation. So thank you so much for this wealth of information. Is there anything else that you'd want our listeners to know about the CLEAR registry or about IV Amoxiclav in general?
Dr. Rupeena, I think just two thank yous. One to you for this wonderful podcast series that you put together. And
Thank you.
two is for all the CLEAR participants. Thank you for all of the individuals across Canada, all the clinicians who are part of the site, they follow it. And thank you to the ones who actually click the links and enter the data so we can all teach each other. So, a couple of thank yous to go around.
Awesome. Thanks so much. We really appreciate you taking the time to come on the podcast. You've done several episodes for us, and all of them have had so much listener love. And we're super excited to hear more about this. And maybe we can do an updated episode when you get some more information in the next year and a half here.
Thank you so much. It's been my pleasure.
Thanks.
Thank you, Dr. Zhanel, for joining us. Please see the episode description for Dr. Zhanel's email if you'd like to be included on the CLEAR registry. Be sure to follow us at CA Breakpoint on X if you haven't already, and we'll see you again soon at the Canadian Breakpoint.